Hey everyone, welcome back to the channel. Today we're going to talk about the pulse oximeter, and a pulse oximeter is a tiny device we usually place on the finger, nose or earlobe, connected to a microprocessor and display which shows us a plethysmograph, a haemoglobin saturation known as SpO2 for saturation proof of oxygen, and don't forget it also shows us a pulse rate as well. So pulse oximetry is incredibly useful because it's cheap, non-invasive, easy to use, and it gives us a continuous trend over time. Even though the displayed saturation lags behind the real PaO2 by about 20 to 30 seconds, it still gives us a trend, which is often more important than the individual numbers. Another use that isn't often mentioned in the textbooks is that the actual tracing of the plethysmograph shape can give information about volume status. For example, when a very dehydrated or hypotensive patient is placed on positive pressure ventilation or takes a big breath in and out, you may observe large respiratory swings in the pleth amplitude. And these swings correlate with changes in stroke volume during the respiratory cycle, just like what we interpret on an arterial line as well. It's not perfect, but it can give you a quick, non-invasive clue about volume status. And the reason it does this is due to the physics of how it works, which we'll talk about next. So pulse oximetry relies on the Lambert Law, which combines two laws. There's Beer's law, which describes that absorption is proportional to concentration that the light has to travel through. So an increase in concentration absorbs more light of whatever substance it is that you're measuring. And then Lambert's law describes that absorption is proportional to the path that the light has to take, or the length the light has to travel through in that solution. So the more distance or length it crosses, the more absorption you would expect. In practice, a pulse oximeter shines specific wavelengths of light through the finger. Then there's a detector on the opposite side measuring how much light arrives at the other end, therefore the light that wasn't absorbed. The probe casing blocks ambient light so the device can focus on the light traveling through the tissues. And every time arterial blood pulses into the finger, the volume increases slightly, which changes the length that the light travels through. And there's also a slight increase in concentration of haemoglobin as well. And this creates a tiny change in absorption that corresponds to the arterial pulse and applies both that Beer's law for the concentration and Lambert's law for the distance the light has to travel through. The venous blood remains mostly constant, so only the arterial blood contributes to the pulsating component, which is the information we care about, hence why it's called the pulse oximeter. Relating back to the comment about volume status, when stroke volume changes over a short period of time, such as with respiration or with stroke-to-stroke variation in atrial fibrillation, this leads to changes in absorption and can be seen on the trace that is formed, which is exaggerated in hypovolemia or intubated ventilated patients, and helps us also understand a potential source of error, which I'll go into later in the video. So we mentioned these two laws and how it's able to determine the pulse side of the blood flow, but we haven't described yet how it tells the difference between oxy and deoxyhemoglobin. So to determine oxygen saturations, we need to distinguish the oxygenated hemoglobin from the deoxygenated hemoglobin. And we do this because we know that each of these hemoglobin have different color, and because they have different colors, they must absorb different wavelengths of light and reflect different wavelengths of light. So the two wavelengths that are used is 660 nanometers, which is in the red light spectrum here on the left on this graph. And this deoxyhemoglobin absorbs more of this wavelength of light because deoxyhemoglobin is a blue color, so it absorbs more red. For the 940 nanometers of light, which is infrared light, oxyhemoglobin absorbs more of this wavelength of light because it's red, so it absorbs more blue light. You can use other wavelengths depending on the different absorption characteristics of each of these species of hemoglobin, but these two specific wavelengths are chosen simply because there's enough separation between them that you can differentiate them, and these particular wavelengths are easy to manufacture and distribute, so they're economically viable. There are also wavelengths where both absorb the light equally, and these are known as isobestic points. And you can see here, these are the points on the graph where both wavelengths or both species of hemoglobin cross each other, and this is at 590 nanometers and 805 nanometers. Some of the older pulse oxes, and in calibrating the pulse ox, oftentimes the isobestic point is used as a reference point. So by comparing how the pulsatile arterial blood absorbs red versus infrared light, the device can estimate the proportion of oxyhemoglobin to deoxyhemoglobin, and this is known as the red-infrared ratio, also known as the R value. Because we only want the pulsatile arterial signal, the oximeter mathematically separates the pulsatile, which is known as AC or alternating current, and the non-pulsatile part of it, which is the direct current, known as DC. And for each wavelength, we need to calculate the proportion of absorption of each of these alternating and direct current. So you end up with equations being alternating current 660 nanometers divided by direct current 660 nanometers. And the other equation is alternating current 940 nanometers divided by direct current 940 nanometers. And then you need to divide the two results to get the R value. So the equation will look like this, being that R equals AC 660 divided by DC 660 over AC 940 divided by DC 940. The R value is a dimensionless number, so manufacturers use human volunteers from studies, or use studies that used human volunteers, to correlate each R value with a real arterial oxygen saturation measured from an arterial blood gas. And because we can't ethically subject people to severe hypoxemia, pulse oximeters are only validated reliably down to about 80%, though some books will say to 70 to 75%. Below this, the reading is extrapolated, so accuracy drops significantly. The general numbers to remember is that an R value of 0.4 equals an SpO2 of around 100%. An R value of 1 equals an SpO2 of about 85%. An R value of 1.4 equals an SpO2 of about 70%. And an R value of 3.4 is about 0%. So to make these R values accurate, you have to be able to measure the signal you want to measure, which is the pulsatile blood flow. And you want to remove all the noise and all the background artifact that's going to disrupt this signal. So only about 1 to 5% of the signal measured is the useful pulsatile component. The rest is all noise that we want to try and remove, and that's from tissues, non-pulsatile blood, motion, and ambient light. So a low signal to noise ratio is inaccurate, while a high signal to noise ratio gives us a reliable reading. So removing noise is an important feature of filtering for these devices. To reduce noise and isolate the arterial signal, the oximeter uses a couple different techniques. The first is that the LEDs light up and turn off extremely fast. It's often greater than 200 Hertz or more. Some people will quote up to 700 Hertz. And what it does is it turns the red light on, both lights on, and then both lights off. Each phase helps identify what part of the detector's signal comes from the LED and what part is from ambient light. So when the lights are off, measurement is subtracted from the others to eliminate room light interference, because once both lights are off, then whatever light is being absorbed must be from the external environment. This rapid cycling must be much faster than the heart rate, because, for example, if you had it at 1 Hertz, meaning light cycles on and off 1 times per second, then it could never measure a heart rate greater than 60, and even then would struggle to be accurate if the patient's heart rate was 60. It would alias and be wildly inaccurate. And this is a key engineering principle behind reliable pulse detection. So when your noise is very high, you're going to have more errors in your reading. And the errors you can divide into patient factors and equipment factors. So patient factors are things such as movement artifact, if there's no pulse, if the patient's on ECMO, or there's an ischemic limb. Low perfusion states such as peripheral vascular disease, cold extremities, vasoconstriction, hypovolemia, and shock. Venous congestion or venous pulsations from severe tricuspid regurg or arterial venous fistulas. Just having nail polish and acrylic nails will attenuate light, and usually darker colours make the light harder to move through, so we'll have more errors. And other hemoglobin species can also give you errors as well. Now, if we go back to our absorption to wavelength graph that we drew earlier, we can see that carboxyhemoglobin, if we draw it on here, is interesting because it actually absorbs red light more than blue light, but gives a falsely high SpO2. But one would reason it should be reading as a low SpO2 because of the deoxyhemoglobin also absorbs more red light than blue light. But in the context of the R value, because carboxyhemoglobin will decrease both deoxyhemoglobin and oxyhemoglobin concentrations due to its high affinity for hemoglobin, the normally greater red light absorption of deoxyhemoglobin will be decreased, but the red light absorption of the combined oxyhemoglobin and carboxyhemoglobin species will be maintained or slightly increased. However, because that deoxyhemoglobin still absorbs red light better than either carboxyhemoglobin or oxyhemoglobin, the reduction in deoxyhemoglobin in the presence of carboxyhemoglobin results in a net effect of decreased red light absorption, and therefore the R ratio that is reduced more than predicted, resulting in an SpO2 that overestimates the fractional oxygen hemoglobin content. So because you have a disproportionate loss of your red light absorption, because you've taken away the deoxyhemoglobin that could potentially absorb that red light, it pushes your SpO2 closer to 100, hence why you get a falsely high reading. So methemoglobin absorbs both wavelengths of light equally between oxy and deoxyhemoglobin, which means that your reading will sit somewhere in between at about 85% regardless of true oxygenation. When it comes to equipment and ambient factors that can cause errors, there's incorrect probe placements, there's ambient light leakage, and then there's dirty or damaged emitters and detectors as well. Another key thing to talk about with pulse oximetry is that a pulse oximeter tells you about oxygenation, but not ventilation. So a patient can be hypoventilating and accumulating CO2 and becoming acidotic while having perfectly normal SpO2. For example, if we pre-oxygenate someone in theatre, patients can actually maintain normal saturations for minutes despite no breaths at all. And this is further exacerbated by the fact that there is a 20 to 30 second delay before sats will drop. So by the time their apnea has led to a desat, they've probably been low in oxygen for about 20 to 30 seconds. And this is why we pair pulse oximetry with capnography to monitor ventilation and oxygenation. So we're essentially saying that the pulse ox doesn't actually tell you if someone is breathing, which is a common misconception. So that's the end of this video. We've covered how pulse oximetry works, the physics behind it, and what the common limitations and inaccuracies are. If you have any questions or anything you want to add, please feel free to leave it in the comments, and don't forget to subscribe to support the channel.